You are telling me that Kenya, like right now as we speak, this evening, around 12 women have already died.
Will have died.
Will have died by close business today.
Absolutely.
From postpartum hemorrhage. How bad is this situation in Kenya and in Africa?
We lose about between 5,000 and 6,000 women every year.
Oh no. Africa as a continent, how are we doing? And even outside the continent, are there countries that have literally 0 cases? And what have they done? What do we need to do?
Our neighbors, for example, Uganda, have reduced their numbers. Tanzania have reduced their numbers.
They're doing better than us?
They're doing better than us.
Uganda, Tanzania are doing better than Kenya.
Rwanda is doing better than us.
Rwanda is doing better than us.
But Rwanda is about 90.
So for East Africa, we are
the sick man of East Africa.
This is the Purity Afya show where we talk about women's health. Here is just to redefine the conversations around women's health. We talk about menstrual health. We talk about what could probably go wrong in a woman's body. My name is Purity Musenzuki, and today we talk about a silent killer. Not just in Kenya, not just in Africa. We were just getting statistics here off air, and we'll get more from Dr. Kirekio Manwa. We are talking about postpartum hemorrhage, and this is one of the biggest or leading causes of death among women. Let's join Daktari as he takes us through this and why our conversations few about postpartum hemorrhage. Doc, thank you so much. It's your first time on our show. We warmly welcome you. Karibu sana.
Thank you so much for inviting me to this show.
Yes, Doc.
Thank you.
We're talking about a subject that is so dear to your heart, and I'm glad I found you on this one. You are telling me that Kenya, like right now as we speak,
yes,
this evening, around 12 women have already died.
Will have died.
Will have died by close business today.
Absolutely.
From postpartum hemorrhage. How bad is this situation in Kenya and in Africa?
First of all, thank you for bringing me here to talk about this. This is a topic which is, I think is a very important topic, which people don't talk about. People don't know about it, but we in the health sector who deal with women's delivery and women's health in general, we actually grapple with it. What we call PPH is part of what we call maternal mortality ratios, MMR. What is maternal mortality ratios? This is the number of women who die during delivery or after delivery, up to 42 days, that is 6 weeks after delivery. When we talk about these numbers, we are not doing well as a country. The government tells us that we lose between 355 to 362 women out of every 100,000 women who deliver. What does that mean? If we deliver 1 million women in a year, it means that we lose between 3,555 to 3,620. But we deliver normally about 1.6 million women. So if we are going to use the same statistics, it means we lose about between 5,000 and 6,000 women every year.
Oh no.
What does that mean? You know, when you talk about 5,000, 6,000 women, it's a number out there. If we break it down, in a month, we will be losing about 360. And then in a day, by the time we finish today, 12th of September, 10 to 12 women will have lost their lives. What causes these deaths? There is what we call the big five. We have the big five in animals in Kenya, and we have the big five in maternal mortality.
Yes.
The number one killer is postpartum hemorrhage, PPH. And PPH is basically excessive bleeding after delivery.
Yes.
The number two, I'll come to the causes later on. The number two killer is what we call hypertensive disorders of pregnancy, whereby there is a pregnancy, and during that pregnancy, especially after the 20th week, your blood pressure starts going up, and it is not well controlled. It affects the baby, it affects the mother who's carrying the baby, and so on. Number three killer is sepsis, maternal sepsis, where there is an infection during soon after delivery or during delivery, and this infection is not diagnosed early enough, and it spreads, generally throughout the whole body, and this leads to death. The number 4 killer is what we call post-abortion complications. Now, one of the late Professor Karanja, who was my senior in the Department of Obstetrics and Gynecology, did a study some time ago. I can't remember how many years ago, maybe about 5, 6, 7 years ago. And what they found out was appalling. In Kenya, there are about 450,000 illegal abortions which are done. And out of those 400,000, 50,000 abortions, a certain percentage of them will complicate. And out of those ones which complicate, a certain percentage of them, I think, if I remember well, about 2,000 or 3,000 will complicate. And out of those 3,000 or so, these are just approximate figures. I don't have the exact figures. We will lose about several hundred because of the post-abortion complications. And then the last killer is obstructed labor. Obstructed labor is basically when a woman is supposed to deliver and she can't deliver. And most of the time, because of bad cultural practices like FGM. So there are societies where they do FGM and they remove everything. They remove the clitoris, they remove the labia majora, what we call labia majora and labia minora, and what they actually leave is a small, tiny hole just for the woman to be able to go for a short call, and that is it. So when she comes to deliver, that passageway, because of the process which was done, it did most of the time they don't heal well. It undergoes what is called fibrosis, where the tissues become very hard, so the baby just can't come through there. So that woman will go into labor. She will labor for 3 days, and the baby is not moving. By the time she gets to hospital, she is tired. The uterus is tired. The baby most of the time has died in the womb, and we have to deliver her by cesarean section. And that now brings us again to PPH again, that sort of thing. So coming to PPH, that is postpartum hemorrhage, we normally talk about PPH when a woman delivers. After a woman delivers normally, that is vaginally, she loses about anywhere between 50, 100, 200 milliliters of blood, which is absolutely fine. But when she bleeds excessively, more than 500 milliliters, then we term that postpartum hemorrhage, excessive bleeding after delivery. And during a cesarean section, she will lose normally about 400 or 500 milliliters of blood. But if she loses anywhere above 1 liter, that is 1,000 milliliters, then that is also termed as excessive bleeding after delivery, postpartum hemorrhage. Some of the causes are very easy to diagnose and even very easy to treat. For example, anemia. When we talk about anemia, is where the blood level actually drops. Normally, the blood level should be anywhere between 11, about 13, 14 grams per deciliter. We have seen patients in KNH where I work. You see patients who come with an HB or that level, hemoglobin level, which is 3.1, which is a quarter almost of what it is supposed to be. Now, if this woman even delivered normally vaginally, and if she loses, even if it's 20, 30, 40 milliliters of blood, she will straight away go into excessive bleeding because her HB, her hemoglobin level right at the beginning was very low. So anemia is one of the biggest problems. 40% of the women who are expectant in this country will have anemia. And if this anemia is not sorted out during pregnancy, they will bleed excessively and most of them are going to die. If you have a big baby, for example, have a baby who is 4 kilos, for example, 4 or even more than 4 kilos, it means that the uterus is excessively, relaxed, as it were.
Yeah.
And it's stretched maximally. So by the time this woman delivers, the mechanism of contracting the uterus are not working the way they're supposed to be working. So she'll start bleeding. Okay. If you have twins, for example, and again, if you have twins or more than 2 babies, that uterus again is excessively stretched. Again, the same mechanism is going to happen. If you have fibroids, if a woman has fibroids, and by the way, 40 to 60% of women of African origin during the reproductive period will have fibroids, and the fibroids can vary in size. And by the way, women of African origin have more fibroids in terms of numbers, and the sizes are also a lot bigger than women of other races, Caucasians and so on.
We'll talk more.
We'll talk about that later on.
Yeah.
That will also lead to excessive stretching, or if not, then the mechanism of contracting, because there are fibroids there, the uterus does not contract or will not contract the way it's supposed to be, so it will end up in excessive bleeding.
Yeah.
If the woman is carrying a baby, and sometimes there is a malformation in the baby. For example, the baby cannot drink the water, cannot swallow the water, because you remember once a baby is in the womb, the baby is surrounded by fluid, which is very, very important because it works like a shock absorber. Now, that fluid is what the baby swallows, and that is the fluid which the baby urinates and swallows again. Now, when you're doing an ultrasound scan, we actually check the amount of that fluid, because it will also tell us whether the baby is doing well or not. So if that amount of fluid is excessive, and it means that the uterus again is excessively stretched. So when the lady delivers, you'll find that the uterus will not contract the way it is supposed to contract. And then you have other causes. For example, if there are tears, the normal delivery is actually a very traumatic experience for the woman and also for the passageway. There is what we call the cervix. If you imagine the uterus as a balloon, and where you breathe the air through to get into the balloon, we call it the cervix or the neck of the womb. So when the baby is coming out, sometimes the neck of the womb, what we call the cervix, can have tears. And if those tears are not recognized, they are not diagnosed soon after the delivery, she'll continue bleeding. And then that also will lead to excessive bleeding, and she can actually lose her life. You can have tears in the vagina itself. If you have a big baby and the baby comes out and there are tears which are not repaired well or not repaired soon enough, that will lead to excessive bleeding. Now, there are also other problems with the placenta. The placenta is an organ which connects the mother with the baby. It is where the baby gets the nutrition from, through the blood supply to the mother, and some of the waste products go back through the placenta and into the mother's circulation, and they come out of the system. Now, sometimes the placenta can cover the passage, the opening where the baby is supposed to come through, what we call placenta previa. Now, if this is not recognized early enough during delivery, this can be a big problem because of excessive bleeding. The placenta can invade the muscles of the womb. The placenta is not supposed to go beyond a certain layer in the womb. So if it invades that layer and goes beyond it, sometimes it can invade even the bladder, which can be in front, what we call placenta accreta spectrum. Now, it becomes very difficult during a cesarean section to remove this placenta which has invaded the muscle of the womb. So you'll end up finding that if you try to remove it, you'll start doing it piecemeal. If this is not diagnosed early during pregnancy, such that we plan accordingly on how we are going to remove it, and if just happen to, tuko na placenta accreta spectrum, and if you're not experienced, you don't know what to do during surgery, this will actually lead to death of the mother.
So, Doc, you mentioned shocking statistics for Kenya. 12 people, it's still ringing in my head that 12 mothers from statistics will die before the end of today. It's alarming. Let's look at Africa as a continent. How are we doing? And even outside the continent, are there countries that have literally 0 cases? And what have they done? What do we need to do?
In the last, let's say, 20 years, there is actually a tendency for these numbers to drop, the statistics to drop. They've actually dropped quite well for about, when you compare where we were 20 years ago, generally speaking in the world.
But still.
And where we are, the numbers have dropped by about 40%, according to WHO statistics. But these numbers have not changed in Africa, especially sub-Saharan Africa. If you look at countries like South Sudan, the maternal mortality ratio is about 1,283, if I'm not wrong. If you look at Nigeria, it's slightly over 1,000. If you look at,
so we are talking
Somalia,
of over 20, over 30 mothers dying in a day.
Yes.
Wow.
Unfortunately, yes. But then, conversely, there are countries where there are almost none or 0. For example, Luxembourg has 0 maternal mortality ratios. You will talk about they're also delivering fewer women, but that is not the point. Countries like Poland, for example, I know Poland very well because I lived there. That is where I trained. I did my undergraduate studies, my postgraduate studies, my PhD in Poland, so I know it well. 2 out of every 100,000.
What are they doing differently?
Countries like the US, we look at the US as being, the paragon of everything. They're also not doing very well as a developed country. It used to be around 15, 18 out of every 100,000. In the last 2-3 years, it has shot to 21. And this has also caused, a big discussion in the US. What has happened that our maternal mortality ratios have increased? This is because the hospitals which are in very remote areas, the US is a very big country. So sometimes the patients may not get to those hospitals early enough, or they are not well equipped because they are so remote. So this has increased their maternal mortality ratios. You asked, what have they done, or what can
That's 0 within a year.
A year.
Wow.
0 or 1.
What are they doing that we need to copy because you say the numbers have not changed in Africa?
They're not changing much. They're not changing much. However, having said that, let me qualify that statement.
Sure.
Our neighbors, for example, Uganda, have reduced their numbers. Tanzania have reduced their numbers.
They're doing better than us?
They're doing better than us.
Uganda, Tanzania are doing better than Kenya.
Rwanda is doing better than us.
Rwanda is doing better than us.
For Rwanda is about 90.
So for East Africa, we are at least...
We are the sick man of East Africa, which is very sad.
Wow.
Which is very sad. Uganda, I think, is about 150, 159. Tanzania...
Like less than 10.
Tanzania is about 165 or 180. Whichever way you look at it, they're a lot better than Kenya.
So what is our problem then? Because we seem to have better equipment, or maybe it's my assumption.
It's the assumption. Let me start by saying, let me quote one professor, late Professor Mohammed Al-Fatah, or Mohammed Fatah. Mohammed Fatah was the president of a society called 𝐓𝐡𝐞. 𝐏𝐡𝐞 is a federation of all the obstetrics and gynecologic societies in the world. And by the way, the present president of 𝐓𝐡𝐞 is a Kenyan. It's a good friend of ours, a colleague from the University of Nairobi, Professor Beatrice Kihara. She'll finish her term next month. Now, this late former president of 𝐓𝐡𝐞 said something which haunts me every day. He said, women are not dying because of diseases which we don't know. We know the diseases that are killing women, but women are dying. And I will adjust that a little bit and say women and women and children, newborns, are dying because we have not made a decision that their lives are worth saving.
Oh no, Doc, you're hurting me. That's a painful truth.
And that is the truth. I told you it haunts me every day.
Yeah.
From where I sit as the president of the Kenyan Obstetrical and Gynecological Society, that women are dying because we have not made a decision. Maybe let me again I adjust that. We have not made a conscious decision that their lives are worth saving.
Oh no.
And that is the truth and the ultimate truth.
So what is this
Let me tell you
now that
why women are dying in this country. Actually, we can call it pillars. Women are dying because we don't have enough personnel. I'll tell you an incident that happened not too long ago. And I use this as an example. This was a private hospital. I had finished doing my surgery and I was going to dress, change and go out. One of my colleagues, senior anesthetist, came to the corridor saying, we have serious PPH in theater 3 or theater 4. So that is an emergency. So I went. There is this young lady, 31 years old. This was her second pregnancy. She had lost the first one, the first baby, at I think 8 weeks. So she had delivered an average size baby, 3.1, 3.2 kilos, nothing really much. And here she was bleeding like a tap of water, which has been opened. She was just bleeding. So my colleague is there struggling, trying to see where this bleeding is coming from. And in such a situation, you need all the help that you may. So I asked her what happened. So she gave me very quickly a brief history about what happened. I said, can I have a look? Because, 2 heads are better than one. So I look, I see the cervix. You remember the cervix that I talked about is intact. There are no tears. So that cannot be the cause. The uterus is contracted. So that may also not be the cause. The vagina, there was a small tear. 3.1 kilos is a very average baby. And she had put 2 stitches and that couldn't. But she's pouring from the uterus like nobody's business. So in the meantime, you can actually hear that anesthetic machine, doing tick, tick, meaning her pressure is starting to do what? To drop. And that is the time you wish you are not an obstetrician. Because it is happening and you see you have to do something about it. So I put my hands inside the uterus through the vagina, and then I could feel something at the back of the womb. And my theory was that she had a fibroid, and the placenta was on the fibroid itself. So when the placenta came out, there are vessels which pass in through the fibroid into the placenta. The vessels could not close because of that fibroid. So what do? So I ask the anesthetist, senior anesthetist, have you given these medications? Yes. Have we given these? Yes. Because there are a series of medications which you can give, which can actually contract the uterus. She had been given all of them. Clapping was happening and she was bleeding. We have what we call abdominal packs that we use during surgery. It's like a napkin, which is about this big. So we pack that in the vagina to stop the bleeding as we are thinking about what to do. After 2 minutes, it's completely soaked. We have to remove it. So I asked if the hospital had what is called a balloon tamponade. Balloon tamponade is a very simple commodity where we where we insert it into the uterus and then we fill it with water. No more saline. Because as it swells, it's a balloon, so it will lie on whichever vessels are bleeding, so it will stop the bleeding. So it will start the process of coagulation and it stop the bleeding. Do you have a balloon tamponade? We've never heard about it in a private hospital. Meanwhile, Purity, she is bleeding like it's the end of the world. So you have to think on your foot. I said, okay, give me a catheter. A catheter is a tube that we use when you're doing surgery. We insert it in the bladder so that it can remove the urine while we're operating. Give me a catheter. So they asked which size. I said, whichever size, give it to me. Give me a size 14. Fine, give it to me. Now, I need a condom. Do you have a condom? Everybody keeps quiet in theater. I need a condom. Meanwhile, she's bleeding. I need a condom. And then one nurse goes out she went out and she came back after a short time. But in that situation, even 30 seconds, 1 minute feels like 20 minutes. So she came back. She said, "Excuse me, I want to say something." I said, "What is it?" He said, "I have a condom, but it was not in my handbag." I said, "We don't care where it was. we need that condom." So anyway, we took that condom. You see, my finger is the catheter. We inserted the condom, and I tied it, and then I inserted it inside the uterus, and then pumped in fluid, about 300 millimeters of normal saline. And we waited for a few seconds. The bleeding stopped. It was such a relief.
Oh, I was waiting for that.
And then we put in an abdominal pack as well. So we waited for 5, 10 minutes, 20 minutes. She's not bleeding. We know we have stopped the bleeding. So we can take her to ICU. Meanwhile, she was getting blood. She was getting fluid through the veins, and so on and so forth. What saved this lady? There were three of us, 3 consultants who were working. Very qualified consultants. There was an anesthetist monitoring how her parameters are doing, giving her medications, ordering blood, giving her fluids, and so on. There were 2 of us on this other side, 2 consultants. Of course, then there was a supportive staff, and so on. That's number 1. Number 2, we had medications. Whatever medications we wanted, we got. Unfortunately, some of the medications we use in this country are fake. So you order, "Give me this." When you inject it, you expect it to work. It doesn't work. So on the ampule, it says we have, let's say, 10 units of whatever it is, but you may find it is half or less than half. So that is why it's not working. Here we had medications, and they were quality medications. Number 3, we had blood. All the blood that we wanted. Kenya collects about 500,000 units of blood. And that is about 60% of what we need as a country. Out of that 500,000 units of blood we collect, 75% of it is used by our mothers because of bleeding. Now, there are some places you go. Yesterday, I was talking to a colleague of mine. They had a death in 𝐷𝗏𝐵, I think 3 weeks ago. And the problem they had, they did not have blood. Ask, "Give me blood." There is no blood. Blood products, it's nothing. We need blood products. It was what we call fresh frozen plasma, which helps in clotting. Can I get fresh frozen plasma? Instead of them thawing in the lab, thawing so that it can be given, analeta kama imeganda fresh. And you see, this is an emergency situation. This needs to be. So, blood. We had blood. And by the way, when this lady came to deliver, her HB was 11.1. By the time she went to ICU, she had lost 2.4 liters of blood. So her HB had dropped from 11. Every 300 milliliters loss is about 1 unit. Her HB was about 3 point something. So she was on her way out. So we had blood. We had medications. Commodities. Here we had to improvise that balloon tamponade. We had that, which helped us. And then we had an ICU unit where she went to recuperate. So these are 5 pillars. You have human resource, you have medications, you have blood and its products, you have commodities, and you have an ICU.
So that's what we lack.
Remove any of these pillars, purity, and it doesn't matter what you do.
So which ones now is the problem in Africa, in Kenya? Because if there are countries with 0, then why are we not making a decision of getting there?
Purity. If you go to most government hospitals, you will not have all these 5 of them at the same time.
Wow.
You will, the personnel will be there. My colleagues are very well trained. We teach them at the university. Some of them are senior colleagues working out there. They will do all this. But then you may find there are no medications, quality medications. Or you'll find there are no medications and there's no blood. You need 8 units, unaambiwa, utapata unit moja, jipange. What are you going to do with 1 unit? Or you find there are no blood, other blood products. Okay? Or you find there are no commodities. Unaona kama hiyo, there was no balloon tamponade, which is something which should be there every time. Or you don't have an ICU unit. When then we say we have an ICU unit, which is a room
you don't have,
which does not have equipment, or a room which has equipment with no personnel. Or you have a room which has equipment and no trained personnel, because we need trained personnel in that. Critical care is a very specialized, aspect of taking care of women and basically people who have undergone surgery.
Okay, Doc, so as we wrap it up, maybe we can talk about, as an association, what you're doing and what governments should do, because Kenya, you said Kenya is the sick bed of East Africa.
Unfortunately, it's a bad title to.
I know, but
it is the truth.
Yeah. So like, we don't even have to go to what European countries are doing. Even our neighbor Rwanda, what some of the adjustments that we need to do to catch up?
Very simple things.
Yeah.
I was in a meeting about 3 weeks ago in Rwanda, and I was talking. I was in their organization. They had a conference, and they invited me to go along. I talked with a good friend of mine, Professor Rulisa. Professor Rulisa was actually being very instrumental in increasing, in basically changing the healthcare landscape in Rwanda. He said when he started working, I think they had they had one woman consultant in the whole of Rwanda. And then I think there were about 5 of them in the whole country. 5 of them. So when he got a position in academia training, and then of course the government saw what he was doing, they brought him on board. He said we need to increase the number of consultants that we have. We need to go to 50, and then from 50 go to 100, and then from 100 and so on. And they have attained that. So now they have consultants. Are they enough? No, they are not enough, but that number is there. Rwanda is the first country, I think, in Africa, or even in East Africa, where they use drones to do what? To supply blood wherever it is needed. Is it difficult to use that? It is not difficult. Some of the policies, health policies, and not only health policies, even other policies that Rwanda is actually using are actually Kenyan. We have beautiful policies.
No implementation.
No implementation. We put them on shelves and we keep on crying. So these are some of the things. We went to Uganda the other day, about sometime last year, to try and understand what they're doing. And actually what they're doing is very simple. They have what is called MPDSR. This is sort of an audit, a continuous audit. What happened to this mother? Why did she have to die? When did she come? What are the gaps, in the system? And they look at this and they say, you know what? This is what the problem was. And during those meetings, MPDSR, which are weekly, they are attended by somebody at the rank of the Director General of Health every week. So government is completely involved. It's immersed in this process. And they say there was a lack here. What was the lack? Oh, we only have one doctor and he's the only one who, okay, then we will get you a doctor. Oh, blood was missing. So what can we do so that blood is available?
There's a deliberate.
Yes, there is a deliberate. And we actually came. It's not that we are not doing MPDSR. We were doing it. The only thing is that we're doing it. Now we are looking at it from a different angle. And we've actually started doing it here. Counties like Homa Bay, they're doing very well. Why? Because the governor herself sometimes sits in that meeting and says, why did this lady have to die? And then she asks her Minister of Health, what are we doing? What is missing? And immediately a decision is made. Buy those medications. If it is commodities which are missing, make sure they are there. So that political involvement is very important. And with political involvement, the money has to flow. What are we looking at? What are we doing as a society? Number one, we are doing what is called advocacy. We are having a PPH run, postpartum hemorrhage run, on the 28th of September from Ulinzi Sports Complex to Timol and back. It's about 9-10 kilometers on the outside. We just want to create awareness amongst the Kenyan population that there is a problem. We are losing far too many mothers, and most of these deaths are actually completely uncalled for. So when we start creating that awareness, you're actually helping us, because people are going to watch your show, and they are going to learn from this. And we also invite viewers, please come for that run.
And we register.
Please register, and there's a website, 𝐴𝐻. Very simple, 𝐴𝐻.
Okay.
So go to the website and register, and let us create this awareness. So that is number one. Number two, we are engaging with the national government, Ministry of Health, and also the county government. Today in the morning, I was with at the Council of Governors, and I talked with the person who is in charge of health at the Council of Governors. A very helpful lady, Katra, said we are going to support, and we support, and they are very helpful, by the way. But this message, these statistics need to get where they're supposed to get, and that is to the governors, to the CECs of health, and so on, so that they take this message personally, because it can happen to anybody. It can happen to the person at the bottom of the pyramid. It can happen. And then lastly, education again, in-service education, refreshing the knowledge that our doctors have, our midwives have, our clinical officers have. We are doing what is called protocols. We are taking our guidelines, and we are trying to sort of synthesize them or crystallize them into a small booklet, which everybody can have who is dealing with women who deliver, such that if there is an emergency, they don't have to go and so they have it. And we are looking at having an app, where they can quickly, go through, with the Gen Zs, they have taught us so many things, So these are some of the things which we are doing. And then we have what we call inter-county MPDSR. There are counties where we've started doing this MPDSR, where we are doing these audits on a weekly basis. Not all of them, not all 47 counties on board, but we've started with Homa Bay, there is Mombasa, there is Nairobi County, there is Murang'a, there is Kiambu, So, and then we want this message to spread, to percolate to every county, such that we can have one MPDSR, for example, where we say, at the national level, they say, look, what is happening in Migori? What is happening in Moyale? What is happening in Mandera? By the way, in Wajir, there are only 4 consultants. 1, 2, 3, 4 in a whole county. So do we expect to help these mothers? We talked about human resource. In Isiolo, I think there is 1 or 2 consultants. And there are some places where there are no consultants. So remove any of these pillars that I mentioned, and we are lying flat.
Oh, Doc, thank you so much. I've learned a lot, and I can tell you have a champion already on the NPPH campaign. I'm disturbed by those statistics, and I know we can do better.
Absolutely.
Thank you so much, Dr. Thank you so much. Thank you so much for watching. I hope you've learned with me that we need to put our efforts together to end PPH, and 12 women, it's such a big number. So I hope the right stakeholders will see this and make a deliberate decision to ending PPH in Kenya. Thank you so much for watching. I am Purity Musenzuki. I'll see you again on our next episode of the Purity Afya Show. Bye-bye for now.